last 12 months relevant to this presentation, same as pharmaceuticals and hyperion therapeutics. And my presentation does include my thanks to the AASLD and the organizers for inviting me to give this update on the... Now, this is a condition that can present with a wide spectrum of potentially reversible neuropsychiatric abnormalities in patients with liver disease and autosystemic shunting. It can lead to a variety of disturbances that at one end lead to impairment of quality of life and social and work functioning, and at the other extreme can lead to coma and death. Patients may present with reports of mental and personality changes, usually coming from family and from friends, asterixis, decreased energy level, impaired sleep-wake cycle is quite common and important to recognize, and impaired cognition, consciousness, or motor function. Now today I'm going to touch on the pathogenesis just to remind us of the basic rationale that has informed the current and developing therapies in hepatic encephalopathy. We'll look at some of the issues in diagnosis and assessment and treatment of the acute exacerbation of hepatic encephalopathy, and we'll take a look at some of the important new data that's come out largely this year on the prevention of recurrent episodes of HE. And then finally, we'll look at the condition of minimal hepatic encephalopathy, in which there's been much interest lately. We'll look at its clinical and social impact, its diagnosis and treatment. Now this diagram reminds us of the central role proposed and still going strong for ammonia and its effect upon brain function in HE. Enteric bacteria are still believed to be the main source of the generation of ammonia in the gastrointestinal tract, and recent work has pointed to a role for bacterial overgrowth in the small intestine, occurring more frequently in patients with advanced cirrhosis and hepatic encephalopathy. There's also been a new appreciation for the role of skeletal muscle and its role in buffering ammonia through its conversion to glutamine, hence emphasizing the need to try and preserve muscle mass in these patients. It seems, despite its central role, that ammonia may not be the whole story, and diligent investigators have still gone on to discover additional potential mediators as diverse as benzodiazepine-like antagonists, inflammatory mediators, manganese, neurosteroids, and cannabinoid receptor agonists as possibly playing a role, and we look forward to seeing these ideas develop further in the future. Let's take a look at the diagnosis and assessment of hepatic encephalopathy, which is really a work in progress. Now, at the World Congress of Gastroenterology in 1998, a working group on hepatic encephalopathy made some landmark strides in classifying hepatic encephalopathy and also proposing various criteria for its assessment and treatment. And here we have the ABC type that they proposed. A for acute liver failure, which Dr. Lee will be discussing in the third talk this afternoon. B for bypass, an uncommon situation in patients who have portosystemic bypass and no intrinsic liver disease. And C for the most common situation that we deal with, and that is cirrhosis, usually with portal hypertension and portosystemic shunting. Now, these forms of chronic hepatic encephalopathy are categorized as episodic, which may be precipitated, spontaneous, or recurrent, and often recurrent, I should add. Persistent, in which there's always some evidence of encephalopathy, either mild, severe, and often treatment-dependent in these patients. These are the patients who miss a dose of lactulose and deteriorate in terms of their grade of encephalopathy. And then there's minimal, that may be clinically inapparent, but nonetheless have an impact, which we'll go into in a moment. Minimal is separated from the episodic persistent group by the terminology overt. So there's overt and minimal, which are the major categories that I shall be discussing. The diagnosis of hepatic encephalopathy is largely a clinical diagnosis, and it is predicated upon a knowledge of existing liver disease in the presence of portosystemic shunting and precipitating factors which are usually present. Patients are often hypertonic, they may show asterixis, and fetor hepaticus, which Hal Conn pointed out many years ago, is the only specific sign of hepatic encephalopathy, which unfortunately few people seem to actually be able to smell and detect on their patients. An important feature of this condition is its reversibility with treatment. There's often testing to exclude other causes of altered mental status, brain imaging, not uncommonly used, EEG and lumbar puncture, less so, and neuropsychiatric testing or neuropsychological testing, something that we use in our practice mainly to investigate the possibility that patients suffer from some other dementia condition, and we look for dynamic changes on serial neuropsychological testing in those patients. But there really is no consensus on diagnostic criteria for hepatic encephalopathy in patients with liver disease, and this, I think, is a heads up to the AASLD and other organizations, because the need to have this now is certainly there. What about blood ammonia? It's quite commonly measured in practice, but we have to point out that the accuracy of this test is very technique dependent. It has to be efficiently drawn. A venous ammonia is fine. There should be no fist clenching, and it should be rapidly transported to the laboratory where they can do a quick analysis. It should go there on ice, and it should be analyzed with pH control. It's not a very specific test, as it turns out. It's elevated in patients on TPN, on patients who have small amounts of gastrointestinal bleeding or urosepsis, and after any form of intense muscular activity. Its reliability in patients with end-stage liver disease is limited. It has a very poor correlation with severity of hepatic encephalopathy. The point here is that it is not always accompanied, HE that is not always accompanied by a high ammonia, but it is almost never associated with a normal ammonia level. Something very important to bear in mind. It's not a guide to treatment. It's often measured as an endpoint in clinical trials, but it's not a useful clinical endpoint for HE treatment in practice. The proper endpoint to be using in clinical practice is the clinical state of the patient. Now, since the original adaptation of the grading of mental status, which was originally a Parsons-Smith proposition, and Hal Conn adapted this into the now well-known West Haven or Conn criteria, we've seen this emerge as the means for assessing the severity of grade of hepatic encephalopathy. But the problem with this grading system is that there are several versions of it out there and no consensus as to which is best. If we just look at what we have here, we'll notice that this is the Ferenczi one. This is from the working group in 1998, and the one from Ammonia and Morgan. The only two places where there are absolute agreement are at grade 0, where there's no detectable change, and at grade 4, where the patients are in coma and not responsive to anything. But if you look at grade 1, here we have impaired performance of addition, and here it's addition and subtraction. If we look at grade 2, subtle personality changes. Heading over here, obvious personality changes, and so forth. Which one is right? We need a little more systemization of this and consensus. Recently, there have been attempts to make the process of grading hepatic encephalopathy more systematic and consistent and less subjective. Now, this table comes from the hepatic encephalopathy scoring algorithm published recently by the group in San Diego, also known as HESA. And for each grade, the patient must fulfill definite assessment criteria in both clinical and simple neuropsychological criteria on testing. And this really does systematize the process in a in an excellent manner, but unfortunately it takes up to 14 minutes to administer a full HESA test. So it's unlikely to become a standard in clinical practice for HE assessment. It is going to make an important contribution, we feel, to the accuracy of severity assessment and stratification of patients in clinical trials for HE treatment. Let's look at the management of the acute episode of overt encephalopathy, which is defined as a West Haven score of 1 or greater. It can typically be diagnosed by clinical examination. It occurs in 21 to 46% of patients with cirrhosis, and it is associated with a significant reduction in survival expectancy in these patients. We of course recognize the importance of numerous precipitating factors that can bring on an episode. Most well-known: infection, renal and electrolyte disturbances, GI hemorrhage, constipation, deterioration in liver function, and many psychoactive medications. And let's not forget non-compliance, and the fact that patients' non-compliance can lead to an episode is certainly a piece of evidence that I think we all recognize as supporting the need for treatment in these patients. The goals of managing that acute episode, as laid out by Andy Bly several years ago, are to provide supportive care, identify and remove precipitating factors, reduce the nitrogenous load in the gut, and assess the need for long-term therapy. Supportive care may require airway protection, intubation in patients with grade 3 or grade 4 encephalopathy. Head imaging is commonly undertaken. And precipitating causes, I gave you the full list a little earlier, but be aware of the fact that dehydration is sometimes contributed to by lactulose, and there is some data coming out now showing that this concern actually does have some true scientific basis, is that the diarrhea of lactulose can in fact contribute to dehydration in these patients. Missed medication doses are important, and infection is sometimes subtle, particularly SPP and urinary tract infections. There are specific medical therapies which we'll touch on. Extracorporeal albumin dialysis, such as the MARS system, may be useful in patients with very advanced encephalopathy, usually stage 4, and often suffering from multi-system organ failure, including severe hepatorenal syndrome. This is still an approach under development. We should never forget that these patients are potential transplant candidates, and that the assessment of this should always be given a priority. Now, what about those specific medical therapies? We have nonabsorbable disaccharides, including lactulose and lactitol in Europe, antibiotics, neuromodulators such as flumazenol, very infrequently used, most useful perhaps in patients who've been exposed to benzodiazepines, and a number of agents that alter the metabolism of ammonia with variable evidence supporting their use, and certainly not strong evidence, including zinc, sodium benzoate, L-ornithine, L-aspartate, and nutritional management. Now, the clinical trials of these specific therapies for the management of overt hepatic encephalopathy have been somewhat handicapped by the fact that, for the most part, small patient numbers have been studied for short durations of time, and the endpoints have been a variable mix of clinical assessment, neuropsychological testing, and neurophysiological testing. And they've been confounded by a really substantial placebo effect that occurs in these overt episodes, which seems to be even more pronounced the sicker the patient is, pointing perhaps to the important contributory role of addressing the precipitating factors in these patients and providing supportive care. Now, lactulose currently is the standard of care in treating these patients, but it is poorly tolerated, and it does have some adverse effects. It's unpalatable, it leads to flatulence, abdominal pain, diarrhea, and nausea, and the osmotic diarrhea that it causes can result in significant hypernatremia, which then has to be addressed as a secondary problem. Now, the credibility